Hi, good night, college. My name is Mireya Figueroa. I'm going to share with you a mini podcast regarding a medication for ADHD. My selected medication is the methylphenidate. I consider it is a good when you have stands with pediatrics and adolescents with ADHD. My opinion with methylphenidate is warranted for the patient as the case presentation of is symptom of clinical disruptive ADHD that interfere the patient with the school, with the inattention, impulsivity, and hyperactivity, and no clear stimulant contraindication. Treatment should prioritize a medication with evidence for meaningful daytime symptom reduction and functional improvement. Methylphenidate meets that standard, but the recommendation remains conditional on baseline risk assessment and follow-up monitoring. The evidence base supports methylphenidate as more than a traditional first option. In addition, a randomized evidence review suggests that the methylphenidate could possibly help with ADHD symptoms and overall behavior in children and also in adolescents, but with limited certainty. That important clinically because I wouldn't say that the methylphenidate is risk-free or it works for everyone. I will offer it as a trial that is supported by evidence and will have measurable goals. Recent randomized trials strengthened this position, reported that once daily, methylphenidate was more effective than placebo for the teacher-rated ADHD outcomes. Another case reported that moderate to high effectiveness of modified release methylphenidate compared to placebo for ADHD symptoms and functional impairment in pediatric patients. The common denominator shared by these studies is that the main symptom and function improve, which is in line with the aim of treatment in the instance. Why methylphenidate fits the case? Methylphenidate also fits this case because formulation choice can match the timing of impairment. A long-acting or modified release formulation can help to cover the patient if they find it most difficult during school hours, when initiating homework or structured tasks, and be less frequent but still effective. This is a clinically relevant point because problems with adherence usually go along with ADHD. Missed dose, stigma, and caregiver monitoring are reduced with once-a-day plan. The objective is not to simply cut down a rating scale score. The objective is to enhance the patient task completion, participation, and attention span during predictable times of impairment. Why the alternative class is less appropriate? The alternative non-stimulant class is not appropriate for this presumed case, as evidence suggests a less clear or less immediate response when the core difficulty is core ADHD dysfunction. But if the children not taking medication for ADHD, concluded SAN, a study previously concluded that methylphenidate had a higher response rate than the atomoxetine, guanfacine, and clonidine. However, have been found to be harmless. Those drugs must be suitable for patients who have a contraindication to stimulants and problems with the tics, sleep issues, diversion history, or are not able to tolerate the stimulants as well. If this patient is free of those factors, however, then beginning with the non-stimulant class would not be as well suited to the need for the functional improvement. Closing argument. Before that, I can to share with you a list of factors, and the monitoring for the medication is very important to be monitoring the appetite, the mood, the sleep, and the improvement at the school, the improvement at home, the behavior at home, the behavior at the school. If the patient doesn't turn any aggressive disorder or any other mood alteration. A closing argument, finally, I recommend using methylphenidate for this patient because there is a good match with evidence, functional needs, and manageable risk. The recommendation should be based on shared decision-making, baseline assessment of signs and symptoms and functionings, monitoring of vital signs and growth, and plans to consider reducing the dose or switch to another therapy if this does not seem to be helping. The proposition then is a not entirely rosy view. A case-based recommendation to use a monitored trial of methylphenidate when there is urgent need and for improvement in impairment in the area of ADHD. Well, have a good night and thank you for here to me. Thank you. Bye-bye.